Great.
All
Awesome.
right, take it away, roll on. They're probably hypoglycemic by now, but I hope just, just get a quick, drink or something and, just hop on or listen on the phone or whichever device that you have on.
All
They're
right.
saying it's small. That's how I see it at my end too. I don't know what it is.
Okay, hold on.
It's like not, is it? Maybe you have to share the whole screen rather than just the PowerPoint.
Is this better?
Yep. I think
Yep.
they're saying that your screen must be huge. I have no idea
Oh,
what you're sharing off, but I think we should be okay, I think. Okay. All right. I see some yeses there. So,
okay. All right. Well, good afternoon, everyone. I'm going to be covering routine bacteriology, so aerobic organisms, anaerobes, and mycobacteriology, as well as some selected comments or about antimicrobial susceptibility testing and resistance. I've put a list of some what I think are some useful resources for review in general, including some hyperlinks. But realistically, as has been alluded to, can't really cover everything in depth. So really, this is going to be some high level and somewhat routine things that are seen but have high impact in clinical decision making. So I'm going to spend very, very short time talking about specimen collection. Hopefully you all know by now, but anything that's collected from the human body, for the most part, can be submitted to the clinical microbiology laboratory for culture. And this does include certain medical devices that are known to cause infections. What's important to remember, though, is that depending on the type of infection a patient has, what we really want to make sure is that we're collecting a specimen that represents that disease process. And ideally, specimens should be collected prior to the administration of antibiotics to increase the overall yield and sensitivity of culture-based methods for recovering organisms for identification and the performance of susceptibility testing if needed. And trying to minimize contamination from surrounding non-sterile sites with microbiota that could impede the ability or the recovery of pathogens, or make it a little more challenging to interpret culture findings in the context of that contamination. And as always, try to get specimens to the clinical microbiology laboratory as quickly as possible to minimize or to reduce the chances of more fastidious organisms not growing successfully. And we're not going to spend a whole lot of time talking about methods, but just know, in spite of the fact that, in the era of MALDI-TOF and sequencing and, PCR and other molecular techniques, there are still a lot of instances where some of the conventional biochemical methods are still utilized to this day. So it's really important to remember that, to remember what these methods are, how they work, and when they should be utilized in routine practice. And of course, while identification of pathogens is important, really it's antimicrobial susceptibility testing that our clinicians are mostly waiting for results. And this is really the essential function, I think, of clinical microbiology laboratories today, is to help our treating clinicians and provide them with the information that is necessary for them to be able to, prescribe appropriate antimicrobial therapy that's going to lead to the best outcome, so treatment success and clinical microbiologic success, so eradication of the organism at the site of infection. And there's a variety of methods that can be done, and these are still in routine practice overnight methods that require creation of an organism, an inoculum suspension, and then testing it phenotypically or and observing the action of these antimicrobial agents against this organism in vitro. So traditionally, broth microdilution or even disk diffusion or gradient strip tests are still utilized every day in practice. There are some rapid AST devices that have come to the market in recent years, and these are very great and promising in the fact that they can provide MIC-based results in a matter of 6 to 7 hours usually, which is much faster, of course, than overnight incubation. The caveat with all of these analyzers thus far is that they're really limited in their indication and scope in terms of the organisms and the drugs in which they cover. Most of these are utilized from a rapid blood culture perspective. So as soon as a blood culture bottle is flagged as positive and growth is detected, being able to identify a pathogen and have some limited AST data and results in about 6 to 7 hours of that blood culture flagging, which is really amazing and helpful, but there are, again, still just limits of these overall. But good to see that technology is evolving. So I've really formulated this with a case-based approach. There's going to be some clinical history, and then in each of the boxes for these slides, you're going to see some additional information, whether it's a physical exam or pertinent findings on a review of systems, and some limited initial diagnostics. But really, this is all going to focus on, again, high-yield kind of bread and butter clinical microbiology. So this first case is a 50-year-old female who has no past medical history, who presented to our emergency department with dyspnea and somnolence. So as a result of her altered mentation, blood cultures were collected and essentially starting up, a febrile sepsis-like workup. And growth was detected very quickly in the first set of blood cultures after about 9 hours, and about an hour and a half later, that second set also flagged positive with the same organism. You can see on her physical exam, though, there was a questionable murmur that was heard. And again, a review of systems notable for altered mental status. And on a routine diagnostic testing, she had a significant leukocytosis with elevated inflammatory markers and a little bit of acute kidney injury. Unsurprisingly, when we gram-stained her blood culture, there were gram-positive cocci clusters the following day. The colony morphology really consistent with Staph aureus. So you see these creamy, golden-looking colonies with significant or pronounced beta hemolysis surrounding them on the agar plate. This isolate was catalase positive and coagulase positive, so we rapidly identified it as Staphylococcus aureus. So there are a lot of clinical diseases that can be caused by Staph aureus. It runs the gamut from simple cellulitis or skin and soft tissue infections all the way to, fulminant severe disease like septic shock. And it is one of the most commonly encountered pathogens in every clinical microbiology laboratory. And when we see it in causing evidence in bacteremia, it's really a sign that an ID consultation is strongly recommended to occur, because caring for patients with Staph aureus bacteremia is notably challenging, and there has to be careful evaluation for evidence of endocarditis to ensure adequate treatment. And just a couple of notes on Staph aureus is that really this is now known to not be a single species, but rather a genomic complex currently made up of 5 distinct species, Staph aureus being the most well-known and the first recognized, but also Staphylococcus argentis, schweizeri, and the newly discovered Staphylococcus rotterdami and Staphylococcus singaporensis. What we know is that all of our knowledge data, if you will, is really based on the assumption that all of what we've seen clinically has been Staph aureus. Probably to a large extent that is true, but we know that looking back historically and performing whole genome sequencing, several of isolates that were previously identified as Staph aureus were actually Staphylococcus argentis, and this is the second most common species seen in this complex. And we also know that Staphylococcus argentis can be oxacillin resistant, just like Staph aureus. So far, to our knowledge, Staphylococcus schweizeri has rarely been associated with human infections, so mostly seen in non-human mammals. And it's recommended that if your laboratory identification system can differentiate some of these, so both current MALDI-TOF instruments that are most widely utilized, the Bruker and the Vitek, do include Staphylococcus argentis in their databases. However, we want to ensure that these don't get disregarded as potential skin contaminants or other coagulase negative staph. So the recommendation is to report them as Staph aureus. Yes, Dr. Viju, what's up?
No, I think there are some questions from the audience, because I think they feel the screen is a bit small. Can you zoom in? I don't know.
Let me stop sharing for again first.
Yeah, maybe try that again. Sorry, I know you're in a flow, and then when I do that,
no worries.
so they're saying they can zoom in. Okay, now they're saying that looks okay. I don't know. To some it seems okay. To some it seems small. I think maybe. Okay, let's see. You're sharing the whole screen, right?
I'm sharing the whole PowerPoint screen. So now, are they seeing it like in the non-presenter view?
They are seeing what I am seeing right now is I can see your slide deck on the left-hand side, and I'm seeing it in a smaller view, and I'm seeing your whole screen of the PowerPoint. Now, if you do the full screen, not in a presenter mode, right? If you're doing play slideshow, what happens?
So now it's back in presenter mode.
Yeah, I think. Do you think you can get one non-presenter is bigger than the presenter view to Oh my God. Okay. I think we're going to get a whole completely different thing. What happens when you zoom in a little bit on that?
So is this better?
It's like, you're at the optometrist who's saying, is this better? Okay, the previous one better. Okay, looks like previous one better. Okay, going fine. We'll just go by the way you had it before. I'm sorry, Nick.
Okay, no, that's okay.
Sorry. We can't please everyone. Sorry. Go with the way. Sorry about that. Okay.
That's okay. All right. So again, just to emphasize that with current technology being able to be a little more specific with our identifications, we want to make sure if your instrumentation is reporting, for example, Staphylococcus argentis, that the lab knows to report this as Staph aureus complex, because how we determine oxacillin or methicillin resistance is different for Staph aureus and other staphylococcal species. So we don't want to misidentify something and have the incorrect clinical breakpoints for our AST applied. So there are a number of ways we can look for oxacillin or methicillin resistance in Staph aureus. This can be done through disk diffusion or MIC-based methods. You can use oxacillin screening augers. You can use phenotypic methods that detect the actual altered penicillin binding protein, or molecular tests that detect the MECA or MECC gene. What's important to note, though, is that oxacillin and cefoxitin are not equal inducers of the MECA gene for methicillin resistance, and really what we know is that cefoxitin is, generally speaking, a much better inducer of MECA. So it's recommended in Staph aureus that you use cefoxitin to check for methicillin resistance, but for other staphylococcal species, including Staphylococcus epidermidis, Staphylococcus pseudointermedius, oxacillin is actually a more potent inducer of MECA. So you really need to know the bug in order to know which drug to better selectively induce to check for methicillin or oxacillin resistance. There are other phenotypes that can lead to some borderline oxacillin susceptibility results, so known as the Borsa phenotype. It's important to note this is not mediated by MECA, but rather by a narrow spectrum beta lactamase called BLAZ. And if you were to do MECA PCR or PBP2A tests, these would both be negative. And there's a mutation of MECA that's known as MECC that can only be detected using molecular methods, and commercial automated susceptibility systems really have varying performance characteristics in trying to identify these based off of phenotypic patterns. And again, we know that MECC, MRSA tend to be better detected using cefoxitin disk diffusion rather than oxacillin or cefoxitin MIC-based methods. However, this phenotype is pretty rare in the United States. So this is just a number of tables that you're going to see throughout my slides, and they're really just meant for some kind of a high-level review to drive home some of these concepts. And again, as I mentioned, with looking for oxacillin resistance, there are a number of methods, and it's really dependent, again, on the species of staph that you've identified to know which method or methods may be appropriate. So this is a table that's been modified but reproduced from the CLSI M100 document, which is kind of like our Bible for antimicrobial susceptibility testing in the clinical microbiology laboratory. And again, you can see that in the orange table at the bottom, for example, for Staph aureus and Staphylococcus lugdunensis, the susceptible cutoff is much different than other Staphylococcus species. So the second case is a 7-year-old male with a sore throat who has pain when swallowing. And it's really important to note that even though I'm talking about bacteriology, and while there are numerous bacterial organisms that can cause acute pharyngitis, especially in children, it's most often seen as a viral illness. And the symptoms of streptococcal and non-streptococcal pharyngitis, so those caused by other microorganisms, do overlap between these. So it's hard to clinically differentiate these. This is why you need good clinical microlabs to be able to perform this testing. There's some really somewhat dated clinical practice guidelines for the diagnosis and management of group A strep pharyngitis that were published by IDSA in 2012. These are undergoing revision, but despite the fact that these are a little old, they are still very relevant today, and the methods that are utilized. So if you are performing a rapid antigen-based test, which is common in lots of urgent care clinics and even physician office laboratories, it's important to note that these lack sensitivity. So if you do have a rapid antigen test, it's culture confirmation is required in order to confirm that a negative antigen test is truly negative. Though if it's positive, you can proceed with diagnosis and treatment. There are rapid molecular tests that are available that have really excellent performance characteristics. Some of these assays have claims that do not require culture confirmation for negative molecular test results. And penicillin or amoxicillin is the recommended therapy, especially if there are no allergies in the patient, though there are alternatives which include clindamycin or clarithromycin. This third case is a very young infant who's only 20 days old, who was brought to the emergency department by her parents because she had 24 hours worth of fever, poor breastfeeding, increased irritability, and what the parents reported as a possible seizure-like episode. The infant was irritable with nuchal rigidity, but had an otherwise non-focal neurological examination. 2 sets of blood cultures were collected, and the patient was admitted to the ICU and underwent an LP before administering antibiotics. And there was a leukocytosis with a prominent left shift, but otherwise laboratory results were pretty much normal. From the LP, we observed gram-positive cocci in pairs and short chains, as seen on the image on the left, from a cytospin concentration of that CSF. And within about 16 hours, the blood cultures that were collected also grew numerous gram-positive cocci, as you can see here, in really nice long chains of cocci. This organism grew on the following day as small white colonies with a narrow zone of beta hemolysis and reacted with the Lancefield serogroup B latex reagent. So we identified this as Streptococcus agalactiae. So this is an infant who had group B strep bacteremia as well as meningitis. This has a pretty low incidence now in the United States of 0.5 per 1,000 live births. And the most common clinical risk factors for the development of this syndrome include maternal colonization, babies who are born prior to 37 weeks gestation, or if there's been a prolonged rupture of membranes leading to delayed delivery. And we can classify this based on its onset as early, late, or late onset, as you can see in the table below. And it's really just based on when symptoms appear relative to birth. So because of this syndrome, we know and routinely recommend screening for Group B strep carriage within 36 and 37 weeks of gestation as recommended by ACOG. And it is recommended to do a combined vaginal rectal culture, which has been shown to be the most analytically sensitive specimen source rather than collecting just a vaginal swab alone. Culture-based testing is still encouraged and recommended, especially if the mother has a penicillin allergy, so the isolate is available for antimicrobial susceptibility testing. But nucleic acid amplification and other molecular techniques as well are recommended in guidelines, though they do recommend using an initial overnight broth enrichment to increase sensitivity for detection rather than doing direct testing off of the swab alone. So this is a one slide on all of the beta hemolytic streptococcal species, the most common species seen, and then their Lancefield groupings. Though it's important to note that some of these organisms do possess and express multiple of these Lancefield proteins. So typing is not always going to give you a definitive answer. And when it comes to susceptibility notes for antimicrobial agents, for beta hemolytic strep, just know that we have to utilize agar supplemented with lysophorus blood due to the fastidious nature of these organisms. And penicillin resistance is really rare in beta hemolytic streptococcal species. And if it is seen, it's recommended to be testing repeated to confirm those resistant results. This third case is a 54-year-old male who came in with a sore throat and cough that had been progressing over the past month. His vital signs were relatively stable with a little bit of a low-grade fever, and his portable chest x-ray showed a consolidative opacity in the right lung field. He provided an induced sputum specimen. You can see the direct gram stain of these colonies that grew after overnight incubation surrounding this optogen antibiotic disc, and these colonies were green, mucoid, and beta hemolytic. So this is a patient with community-acquired pneumonia due to Streptococcus pneumoniae, which is the leading cause of community-acquired pneumonia in adults. Important to note that despite our diagnostic advances, it is in a large proportion of cases, upwards of 25%, in some instances, probable pathogens in CAP cases are unable to be identified. And the table on the right is just listing some of the typical bacterial causes along with atypical causes, and then viruses as the other leading cause for community-acquired pneumonia. And this table is again a review table on some of the different viridin Streptococcus species. I'll just point out that Streptococcus pneumoniae is within the Streptococcus mitis group. And while classically all of the other alpha hemolytic streptococcal species other than Strep pneumoniae were really thought to be considered contaminants, we know of course that these can be pathogens in the setting especially of endocarditis. And again, some AST notes on Streptococcus pneumoniae is that for certain drugs, for penicillin and cephalosporin antibiotics, there are really 3 different breakpoints for Streptococcus pneumoniae, and it really depends on the site of infection and how we interpret these AST results. So there are meningitis, non-meningitis, IV, and oral breakpoints for these different drugs. And this is really meant to, again, to reflect the severity of disease as well as the prolonged course of therapy that may be needed. This next case is a 27-year-old male with a really complicated history and was a liver transplant patient who ultimately had a very unfortunate course and developed increasing respiratory failure and had BAL and pleural fluids growing, an invasive mold, a rhizopus species, and subsequently continued to worsen and had evidence of pericarditis with an echo that showed an ejection fraction of 60% with a right atrial systolic collapse. The patient underwent a left pneumonectomy with a partial pericardial resection, and blood cultures and fluid cultures from the pericardium grew the following organism of Enterococcus faecium. And you can see here the positive gram stain from his blood culture showing numerous gram-positive cocci in pairs and chains, and then growth of the colonies the following day. So enterococci are catalase negative gram-positive cocci. There's a large kind of group of these catalase negative gram-positive cocci that can cause infections. And this table is really, again, just meant as a review. What we know about enterococci and that what we're most concerned about, though, is vancomycin resistance within these species. So there are a number of ways that we can determine vancomycin resistance through formal susceptibility testing, screening using chromogenic or other selective augurs, or molecular testing looking for specific genes that encode this phenotype. The mechanism of resistance for VRE is that vancomycin works as an antibiotic by inhibiting the cell wall precursors, and it selectively targets and has an affinity for those D-alanine terminal moieties of the growing peptides. Mutations within the cell wall change and alter this binding site and change the ending amino acid protein terminus to lactate. And lactate has a much lower binding affinity for vancomycin compared to alanine. And vancomycin resistance is common in both Enterococcus faecium and Enterococcus faecalis, which are the two most commonly encountered species, but we see it more in E. faecium. It's important to note that VAN A and VAN B are not the sole genes that can encode this phenotypic resistance to vancomycin or really to other glycopeptide antibiotics, though VAN A and VAN B are the two that we worry about from an infection control standpoint because these are acquired that can be found on plasmids, whereas others, such as VAN C, which is an chromosomally intrinsic resistance mechanism, is really restricted to only a few species. Other concerns within enterococci include to look for or detect the presence of high-level aminoglycoside resistance. While enterococci are naturally intrinsically resistant to aminoglycosides, so they're not effective if they're used as monotherapy, it is recommended to perform synergy testing because these agents are often given in combination with a cell wall active agent such as ampicillin or vancomycin, provided that high-level synergy testing suggests that the isolate will be susceptible. And while disc-based methods are available, if those are inconclusive, recommendations are to proceed with MIC-based methods. And most commercial antimicrobial susceptibility systems include screening for high-level screening with gentamicin, streptomycin, or perhaps both of these agents when you have an enterococcal isolate that you've identified. This next case is a 63-year-old woman who presented with a 4-day history of fever, headache, and confusion. She reported having a case of diarrhea that self-resolved a few days prior to her current symptoms. Her only significant medical history is rheumatoid arthritis, and she's currently taking prednisone. You can see kind of some initial testing from a lumbar puncture that was performed in this woman. She had a pretty significant pleocytosis with a decreased CSF glucose and an increased CSF protein result. And blood cultures were also collected. Her CSF culture and gram stain revealed numerous gram-positive rods that grew as very pinpoint colonies on blood agar. This was ultimately identified as Listeria monocytogenes. And it's important to note that the colony morphology for Listeria can resemble Streptococcus agalactiae. So it's really important to always perform your gram stains to ensure that you're not going to work down the incorrect pathway of identification when you're reviewing your culture plates. So this is one slide on different causes of meningitis, whether they're viral, bacterial, tuberculous, or cryptococcal meningitis, and then stratifying the most common bacterial pathogens for acute meningitis based on age or a couple of selected scenarios. And I can't talk about all of the gram-positive rods of significance, but this is an area where it's really important to know and really get comfortable with gram stains because aerobic gram-positive rods and the most common species, which I've tried to include here in this table, really have unique morphologies in appearance and size. So it can be very helpful in eliminating some potential organisms from your differential, as well as including in those that are most likely to resemble these. Again, some pictures here for you. This next case is a elderly Hispanic male with a past medical history of hypertension, hyperlipidemia, and a significant smoking history who presents with progressively worsening fatigue, weakness, and unintentional weight loss for the past couple of months. He was originally from Mexico, but emigrated to the US 50 years ago. You can see his chest x-ray in the upper right really looks horrible. He also subsequently underwent a CT chest, which showed extensive miliary nodules in both the right and left lungs, with a central cavitation that was most pronounced in the upper lobes. Numerous diagnostic studies were ordered and testing was in process, including sputum cultures, AFB cultures, antigen testing for Histoplasma legionella, and quantiferon. What we saw on his, the patient also subsequently underwent BAL. And what grew out of his sputum and BAL, as seen on the image on the right, is a nice auramine rhodamine stain, which stains for mycobacteria. You can see numerous bacilli fluorescing that nice yellow-orange color, which indicates that this patient has a mycobacterial infection. All of his smears were positive for AFB. We did a rapid PCR that detected the Mycobacterium tuberculosis complex. No rifampin or RPOB gene mutations were detected, indicating that this isolate should most likely be susceptible to rifampin. The patient's quantiferon ultimately came back negative, and growth was detected in our liquid-based media for mycobacteria after about 9 days. And subsequently, the susceptibility results that came back indicated that this was a susceptible strain of Mycobacterium tuberculosis. So TB continues to be a leading cause of death in adults worldwide, with nearly 2 billion cases occurring, with the highest incidence of cases in sub-Saharan Africa, India, Southeast Asia, and Micronesia. And by far the greatest risk factor for developing infection with a member of the Mycobacterium tuberculosis complex is immunosuppression. And you can see the species that make up this complex in the table on the right. So really important to think about MTB or include that in when you see buzzwords such as fever, shortness of breath, night sweats, and others. And again, risk factors include being foreign born or having recently emigrated to the United States, patients who've been incarcerated or persons who experience homelessness, and those who are immunocompromised, or if patients have ever had a diagnosis of latent TB, especially if they were not treated, latent TB progressing and developing into active TB. And this is a beautiful image from a colleague seen on the right of the phenomenon known as of cording on a Kenyan-based stain that MTB is not solely unique for, but always kind of fun to look at. There are other mycobacterial species, over 200 in fact, that have been identified, identified, though not all causing infections, but there are a general number of these that are free-living organisms in the environment, so exposure to these occurs quite frequently. They most often cause pulmonary infections, but also skin and soft tissue infections, and in immunocompromised hosts can disseminate and go anywhere. One big call out is Mycobacterium leprae, which is an organism that is unable to be cultivated, so it does not grow in vitro. So diagnosis is typically made clinically and in combination with biopsies and histopathologic examination, revealing acid-fast bacilli. And this is the organism that causes Hansen's disease. This next case is a 33-year-old female who has 3 months of fever and cough that's really not improved, and 1 month of limb weakness and new onset of headaches. She had a CT chest that showed a few pulmonary nodules, and because of her CNS complaints, underwent a diagnostic MRI as well as a lumbar puncture, and which you can appreciate in the MRI images on the upper right, hopefully. These are T2 flare weighted images, so you're seeing hyper intense lesions and almost like a ring-like lesion at each of those red arrows, with some surrounding edema on the in the left lobe. Her CSF was significant for a large pleocytosis of 17,000 cells per cubic millimeter, and a significantly low glucose and elevated protein. So this patient was ultimately diagnosed with nocardia. Nocardia brasiliensis was the organism that we identified in her culture. This syndrome, these are environmental organisms, and they're mostly described as opportunists that cause infections in immunocompromised hosts. However, both immunocompetent hosts are able to be infected with this organism as well. And we tend to see, though, most of the nocardia CNS infections in patients who have some degree of immunocompromise. They're unique in that they are aerobic microorganisms, but they have a beaded and branching appearance on gram stain. I know the gram stain image is a little faint and hard to see. There's a lot of background of all of the pus, but hopefully you can appreciate kind of in this upper area, all of this kind of faint purple staining. This isn't staining artifact, and they're not gram-positive cocci and chains, but this highlights the appearance of nocardia having this filamentous branching appearance on gram stain due to the imperfect uptake of the crystal violet. Nocardia is partially acid-fast, so if we modify our acid-fast stain that is utilized for mycobacteria and use a gentler a gentler acid to decolorize, so sulfuric acid instead of hydrochloric acid, these cells retain the primary stain, the carbofuchsin, so they'll appear red on your modified acid-fast stain, as seen here in the lower right. What's important to remember about patients with nocardia is that oftentimes this is a very subacute and indolent kind of progression of this disease that can last for several weeks to months. And while this organism grows on most routine media, it grows best on charcoal-based media such as BCYE or on media that's utilized for mycobacterial cultures or fungal cultures. This next case is will probably be one of the most simplest cases, but it's a 27-year-old woman who went to her primary care physician with complaints of a couple of days of dysuria and suprapubic pain. She was afebrile with normal vital signs. They did a UA that showed findings in the box above, and subsequently she provided a specimen for culture that grew greater than 100,000 colony-forming units of a gram-negative rod. You can see the colony morphology that we identified of this lactose-fermenting gram-negative rod based on the McConkey agar you see on the lower right corner. So this was a catalase positive, oxidase negative, and indole positive organism. So this was a patient who had an E. coli urinary tract infection. E. coli is the #1 urinary tract pathogen that causes both cystitis or pyelonephritis in adults, and it's also the #1 most seen pathogen in pediatric patients. But you can see how there is a little bit of differentiation in terms of epidemiology of these organisms based on syndrome and age. We know that resistance, especially among our gram-negative pathogens, is increasing over time. The most common risk factors include broad-spectrum antimicrobial use, frequent healthcare exposures, or international travel. And first-line agents for simple cystitis, in patients without risk, we typically look for non-beta-lactam alternatives like nitrofurantoin or fosfomycin, which are relatively short courses of antimicrobial agents that can be prescribed. When we do encounter resistance, as seen in this example of an isolate antimicrobial susceptibility pattern, it's really important to look at which agents are we seeing resistance in to help kind of identify and look for potential mechanisms. So in this example, we're seeing resistance to some of the narrow spectrum beta lactams and first, second, and third generation cephalosporins. But this isolate is notably susceptible to carbapenems, in this case, meropenem. So we would think in this phenotype, this patient might have an organism that is possessing an extended spectrum beta-lactamase or an ESBL. There are ways we can confirm ESBL production, both using disk diffusion or MIC-based methods. And we do this by testing third-generation cephalosporins alone and in the presence of a beta-lactamase inhibitor, in this case, clavulanic acid. And we're looking to see if when we add clavulanic acid, is the organism now susceptible? And there are different criteria for those interpretive cutoffs that you can see here on the slide. If, however, we have a really broadly resistant isolate, in this case that includes resistance to carbapenems, now we start to worry not about ESBLs, but of another form of resistance known as carbapenemases. So for carbapenemase production or detection, there are a number of phenotypic and molecular methods that can be utilized. I'm a fan of some of these more rapid lateral flow assays that provide results for some of the most common carbapenemases that only take about 15 minutes. Culture-based methods like those that are endorsed by CLSI, including the MSIM and CarbaNP, are fine analytically, but they do require overnight incubation, so a little slower. But there are other rapid alternatives, including molecular assays that are available to detect these common carbapenemases as well. This is one slide on some of the most common types of beta-lactamases that you'll encounter in gram-negative rods. So a great resource for you. This next case is a 20-year-old female seen in an emergency department for a dog bite to her right hand. She underwent wound irrigation and sutures and was prescribed amoxicillin clavulanic acid and represented with swelling and redness. The sutures were removed. A wound check revealed frank pus. This pus was cultured. There was no growth of this organism on MacConkey agar, but we did see growth on the blood agar. And when we stained it, we saw these very small gram-negative coccobacilli. Or gram-negative rods. The isolate was identified as a Pastorella canis, though Pastorella multacida is the most frequently isolated and probably most well-known species. There are other Pastorella species, and many of these are common members of the microbiota of rodents, dogs, and cats. And they can often have bipolar staining. They grow well routinely on blood and chocolate agar, but don't grow on MacConkey agar, and that's our selective agar for gram-negative rods. And we tend to get better recovery of these organisms when they're incubated in CO2 enhanced environments. With regards to susceptibility testing for Pastorella, not routinely needed for wound specimens or non-sterile sites, because we know generally speaking that they're susceptible to penicillin as well as other broad spectrum cephalosporins and a number of other oral antimicrobial classes. Notably, they are resistant to clindamycin, so we typically get by with just performing beta-lactamase testing for these wound culture, as in this instance, which is recommended by CLSI. And this beta-lactamase testing is a rapid chromogenic-based test that only takes a few minutes, so we're not delaying things for overnight incubation. There are numerous gram-negative rods that are, again, commonly seen. You can group them in different ways, whether they grow or don't grow on MacConkey agar, differentiating them based off of their oxidase results, which is a common, quick, rapid biochemical. We can't go into all of these, obviously, for the sake of time, but just know that many of these are like Pseudomonas, Acinetobacter, are fairly commonly seen in clinical microlabs. This table, though, is just, again, trying to summarize in one slide some of the more frequently encountered fastidious gram-negative rods. So these are all gram-negative rods that will not grow on MacConkey agar. This next case is a 62-year-old male who had a few days of left-sided chest pain, shortness of breath, and a productive cough. He's got some significant past medical history, and on his routine sputum culture, there was no growth of any probable pathogen, so just some normal respiratory flora. You can see, though, he has some pretty significant lower left-sided lower lobe pneumonia, and his oxygenation is pretty poor at only 90% on room air and continued to deteriorate. Was transferred to the ICU at our institution for acute respiratory distress. And subsequently underwent a bronchoscopy, and BAL specimens revealed this organism growing on charcoal-containing media, or BCYE agar, these medium to large gray colonies. This patient was diagnosed with Legionella pneumophila, which is a really common cause of community-acquired pneumonia. And I always recommend to trainees to think about if you have patients or cases or people who've seemingly been treated for community-acquired pneumonia aren't improving on something like a beta-lactam, like amoxicillin or amoxiclav, and develop worsening oxygenation and really crash and have to go to an ICU, Legionella should always be checked for. There's rapid testing, which is really useful, Legionella urine antigen testing. However, this only detects serogroup 1A of Legionella pneumophila, and Legionella pneumophila is not the only Legionella species that causes a syndrome like legionellosis. We know, though, that this organism has an exclusive environmental reservoir. There's really no person-to-person transmission. It's all transmitted through aerosolization and droplets of the organism within water sources. And these organisms and Legionella cannot be treated with beta-lactams. They're ineffective. So you really have to treat them with either a fluoroquinolone or azithromycin. Real quickly on anaerobic microorganisms, just know that anaerobes can cause infections anywhere. They tend to be polymicrobial, so you're not going to just see one potential pathogen, you're going to see numerous, and they're really a result of trauma, barrier damage, or some type of underlying disease that is impairing your host defense system. And you should really think anaerobes may be present in an infection if you have a polymicrobial gram stain, or clinically if the clinicians or patient reports foul odor, or you detected gas formation in soft tissue. Those are all classic hallmarks for an anaerobic infection. And just know that this is to describe and to differentiate what we mean when we say anaerobes. We're really talking about our obligate anaerobic organisms that do not grow in the presence of oxygen. So think Clostridium and other species. This table just includes the most commonly encountered anaerobes based off of their gram reaction and morphology. I have one slide on select agents. These are category A agents. These are things like Bacillus anthracis, like Francisella, like Yersinia pestis. Patients do present with infections with these organisms naturally, and it's really important that clinicians alert the laboratory if they suspect an infection with one of these etiologic agents so that we can protect our laboratory staff and to minimize exposure. And the goal of this is to do something known as to rule out the agent, and if you're unable to do that, to refer it using as little manipulation of the specimen and the culture itself, and doing the least amount of testing as possible, and all in efforts to, again, prevent unnecessary exposure. And this is a table on the 6 or 7 select agents, their gram reaction, colony morphology, and then the limited amount of rule-out testing that we can do. Notice we don't put these isolates or organisms on automated systems like MALDI-TOF or your VITEC or your Microscan. They're not meant for that, for risk of aerosolization. And with that, thank you so much. I know that was a whirlwind. I'll stick around for questions in the chat afterwards, but I know Dr. Stempak is up next. Thank you.
Thank you, Dr. Moore. Sorry, I had stuffing my face with food, I hope.
No.
I hope the boat takers also managed to get a bite to eat. I think that was a rapid fire overview and perfect timing as well. So let me just have, I don't think I have Dr. Stempak as a co-host. Let me do that. And I think she should still be able to share her screen without that. So it's my pleasure now to introduce the next speaker. This is an awesome combination between Dr. Moore and Dr. Stempak. Dr. Stempak is currently Vice Chair Pathology Laboratory Medicine at Cleveland Clinic, and she's going to run with the rest of it, which is mycology, parasitology, and virology. Dr. Stempak, can you share your slides and can you say something so that the audience can hear you?
Yes. Good afternoon, everyone. Are you able to see my slides?
Yes, we can, and we can hear you, so you can take it over.
Okay, very good. Thank you for joining, everyone. I did put my PDF of the slides in the chat, so you should have them. As was shared previously, this is going to be a fast-paced review of mycology and parasitology. I did put a couple slides of virology at the end. We probably will not get to them, but they are there for your reference. My goal was to cover as much of the information as possible, particularly those points that I thought were high yield. So in no way is this comprehensive about each and every organism, but I did try to highlight the most relevant points for your board preparation. And so we'll start with mycology. Mycology is the study of fungi. Fungi are eukaryotes. They have chitin and glucan in their cell wall, as well as ergosterol in their cell membrane. This is different than human cells, which have cholesterol. So that makes chitin and ergosterol important antifungal targets for therapies to treat them. Fungi are divided into two categories: the yeast, which are usually unicellular. They reproduce by budding or fission. They have pseudohyphae, which are daughter cells in change. And morphologically, on culture, the colonies are pasty, they're discrete, some can be mucoid or flat colonies similar to bacteria. Our second category of fungi are the molds. Molds are multicellular. They have tubular hyphae, and these hyphae come together to form mycelium, when this creates the fuzzy, kind of indistinct colonies that we see in the laboratory. And so taking a look at what yeast look like, I show some drawings here illustrating budding yeast, as well as an example of Cryptococcus neoformans here, as well as pseudohyphae with the branching occurring at the junction. And this is a typical example of Candida species. In contrast, molds have septations. Here's a septate hyphae. You can see the branching coming off at the center of the hyphal unit here. Here's a nice example of Aspergillus species with very parallel walls, discrete septations, and 45-degree angle branching. Another example of molds are the aseptate or pauciseptate molds, where our where our septations are less numerous. The walls are wider, they're less parallel to each other, they're somewhat wavy, and the branching typically is more of a 90-degree angle. These are the organisms that we're going to cover today. We'll cover Candida, Cryptococcus, Malassezia are examples of yeast. And then there are 5 main categories of mold that we'll cover. The dimorphs, which are particularly important. These are the category where we have yeast that grow at 37 degrees, and that's typically what we see in the body, that's body temperature. And then we have molds that grow in the lab when they're incubated between 20 to 25 to 30 degrees Celsius. Our hyaline septate molds are going to be clear and non-pigmented, in contrast to the dermatiaceae, which are pigmented due to the production of melanin. We'll cover mucorales, which are those pauciseptate molds, and then finally wrap up with the dermatophytes, which are cause superficial skin infections. So jumping right into some common examples of Candida species. First is Candida albicans. Here's what the colonies look like on agar when grown in the lab. And Candida albicans in particular has these characteristic feet-like projections that come off the colony. That is unique to Candida albicans. If we were to grow this organism on cornmeal agar, what we would see is clusters of Blastoconidia, which is shown in these 2 middle images here, with terminal chlamydospores. Recognizing that cornmeal agar is not used for the identification of yeast very much anymore today. We use automated methods and phenotypic biochemicals or MALDI-TOF to make the identifications. The other important test for Candida albicans is that they are germ tube positive, and that's illustrated in this picture up here in the upper right-hand corner. This is a tube-like projection from the parent cell, and there's no constriction at the neck here. So these top 4 pictures all illustrate Candida albicans. Our next Candida species is Candida krusei. Candida krusei on cornmeal agar has a matchstick morphology to its pseudohyphae. And important to know about Candida krusei is that it is intrinsically resistant to fluconazole, which is a common antifungal that is used to treat Candida infections. Our last Candida species is Candida glabrata. Candida glabrata is unique in that it does not have pseudohyphae or true hyphae. It just has these small yeast cells here. An important fact about Candida glabrata is that it has an unpredictable resistance pattern to fluconazole. Some can be susceptible, some can be outright resistance, and then there's a third category of susceptible dose dependent, where if you can get a high enough concentration of fluconazole, it might be a viable drug to treat Candida albicans infection. The next yeast we'll talk about is Cryptococcus neoformans. Now, Cryptococcus neoformans causes pulmonary as well as CNS infections, particularly in patients that are immunocompromised. And what we see in the laboratory is these very discrete mucoid-like Candida colonies resembling Candida albicans. When we look at Cryptococcus neoformans under the microscope, we see various sized yeast cells. They can range in size from 2 to 20 microns, and they're described as being like beads of water on glass. They don't touch each other because of the presence of the capsule of Cryptococcus. The capsule is a major virulence factor, and it will stain with both mucicarmine as well as Austrian blue. We can also use India ink to highlight the presence of the capsule for Cryptococcus neoformans. Not really used much anymore today, but an important feature to aid in a quick diagnosis many years ago. Cryptococcus neoformans is urease positive, and so that's shown here with this pink color. It's also positive for phenyl oxidase. And so if you were to grow Cryptococcus on birdseed agar, what it does is it converts the compounds that are in birdseed agar into melanin, and the colonies grow this dark color. If you were to see Cryptococcus in histology, it would stain with GMS, PM, and PAS, as well as mucicarmine and Austrian blue. Diagnostic tests that are helpful include antigen testing, both from blood as well as CSF, PCR, MALDI-TOF mass spectrometry. Our final yeast that I wanted to cover today is Malassezia furfura. Malassezia causes tinea versicolor, which causes hypopigmented skin lesions, particularly of the trunk and back. It can also be associated with TPN-related sepsis in neonates due to the high lipid content of the TPN. Malassezia does require lipids in order to grow, and so we can see here plates that have been, the specimen has been applied to both plates, but this place here on the left has an olive oil overlay, which provides that lipid content that's necessary in order for Malassezia furfura to grow. If we were to look at it under the microscope, what we see are small yeasts that have broad-based buds. I think the best examples are shown here. And you can kind of see this collarette between the two yeast forms there. If you were to perform a KOH stain, it can have a spaghetti and meatballs appearance, which is shown here. And as far as treatment with Malassezia, it is intrinsically resistant to the Echinococcus class of antifungals. Now we'll transition to the mold, and we'll start with the dimorphic fungi. These can be, the majority of them are systemic, and then we do have one localized, which is Sporothrix shankii. And of the systemic, they have a particular geographic location where they cause infection. You can see them listed here, and we'll cover them in the upcoming slides. So the first is Histoplasma capsulatum. Histoplasma can be found in the Ohio and Mississippi River valleys, particularly can be associated with bird guano, bat droppings. So people that are cleaning bird roosts or attics, people that go spelunking in caves where there's a lot of bats could be susceptible to this infection. Many of the dimorphs are acquired through inhalation and cause infections in the lung, as well as can spread to other organs as well. So the yeast form of histoplasma that we'd see in tissue are these small uniform yeasts that that have narrow-based buds. The yeasts are anywhere between 2 and 5 microns in size, and you can see them within macrophages, and this is what is seen here from a bronchoalveolar lavage specimen. In contrast, the mold, it's a slow grower. It might take 10 to 14 days to grow, and you can see it growing here as some fluffy white colonies. The hyphae are thin and septate, and we see some microchlamydia, but particularly the diagnostic feature that you're looking for are these larger round tuberculated macrochlamydia, which are shown here in this lactophenol cotton blue prep. I think culture and histology are the most common ways to diagnose the dimorphs. There are some urinary antigen tests, particularly for histo and blasto, that can aid in the diagnosis, but they do show some cross-reactivity with each other. PCR is an option, and serology is less common currently. Our next dimorph is Blastomyces dermatitidis. This is found in a similar region overlapping with histo, but also goes down into the southeastern United States as well. You can see blasto, particularly with decaying vegetation in soil, in the woods. Dogs actually can become infected because they oftentimes have their nose to the ground. What we see as far as the yeast form, you see these broad-based buds, which is illustrated here, about double to triple in size compared to histo, anywhere from 8 to about 16 microns in size. They have a double contoured cell wall. And if we were to look at them in tissue, they have this pyogranulomatous reaction, lots of neutrophils. And blasto has a predilection for skin infections, bone infections, can also go to the brain as well. What we see in the laboratory when it grows as a mold, it is a slow grower, 10 to 14 days to grow. And you see these filamentous oval to pear-shaped conidia that resemble lollipops on a stick, and often on the terminal hyphal branches. Diagnosis is similar to histo. Again, we see examples here on this slide of culture and histology. There is a urine antigen, and you can use PCR and serology as well. Our third dimorph is Coccidioides immitis, much different geographic location than histo and blasto. We see this in the desert in the southwest United States, in the Sonoran life zone, which is low altitude but very high temperatures. Exposures are often greatest when there's a drought and there's lots of wind, or right after the rainstorm when the dust is stirred up. In tissues, we see these large spherules that range in size from 20 to 60 microns, and they're filled with endospores. That are about 2 to 5 microns in size. That's very similar to the size of histo, so it's important to look around, look at the patient's history, where they have traveled, so you can make sure you get a full picture. In the laboratory, Coccidioides grows as a mold. It grows rapidly, a handful of days, 2 to 3 to 5 days. It's white, it's fluffy. And what we see are these infectious arthroconidia. They're barrel-shaped, and sometimes you can see an annular frill at the ends. So we've seen examples here of using culture and histology to diagnose. PCR as well as serology is available as well. Our next dimorph is not commonly found in the United States. This is Paracoccidioides brasiliensis. Can be seen in central Mexico, Central America, and South America, particularly in areas where there's relatively cool temperatures, but there's a high humidity. People that are particularly at risk are those that have occupations with wood cutting, and people that use toothpicks or chew on bits of plants that can cause Paracoccidioides infections in the oral cavity. What we see in the yeast form, these are large, and they're going to be round, that have thickened walls, and then they're going to have these narrow-based buds, and there will be multiple of them. And this will resemble a mariner's wheel. So that is what's shown here. What we see in the lab when it grows as a mold, Paracoccidioides is a slow grower. It's a white to brown mold, and you see here these lollipops on a stick, and they're located on the terminal hyphal branches. This is the exact same description that we shared for blasto, and it is indistinguishable from blasto. Ways to make the diagnosis are listed here. Serology is available in endemic areas. Our last systemic dimorph is Tarlomyces marneffii, whose name was changed in the past couple of years from Penicillium marneffii. This dimorph is found in Southeast Asia. It's found in the soil and on decaying material in areas where it's humid and rainy, and there is some association with the bamboo rat spreading this organism. The yeast is described as oval yeast-like cells. They have this prominent central septum, and these yeast reproduce by fission. There is no budding. In the laboratory, when it grows as a mold, it is a rapid grower, and it's characterized by this deep red diffusible pigment. This is not a blood agar plate. This is the diffusible pigment from the mold form. What we see when we look at the colonies under the microscope, there's a smooth conidiophore that's shown here. This is the structure that bears the conidia. You can see a layer of metula, and then phyllids, and then the infectious conidia are round to oval and smooth. Culture is the same as all our other dimorphs, with serology being available in endemic areas. Our last dimorph causes localized infections, and this is Sporothrix shankii. Superficial infections that may spread to regional lymph nodes. There's really no particular geographic area for this localized dimorph, but it is found commonly in soil, on thorny plants, and particularly gardeners and landscapers are at an increased risk for infection. What we see in tissue, there are yeast cells that are oval to elongated, and they're described as having pipe stem buds. They're narrow base buds, and they can be commonly called cigar bodies. What we see is a Slender-Hopley reaction occur around the yeast, and that's illustrated in this picture here. When Sporothrix grows in the lab, it grows within 7 days, and it has these very delicate septate hyphae, slender tapering conidiophores, and then the tear-like conidia, which are shown here, they cluster in a rosette pattern, resembling daisy head appearance. And so you can see that in this picture down here at the bottom. Culture and histology are our main methods to diagnose Sporothrix. So that wraps up the dimorphs. The next category we'll talk about is the hyaline septate molds. Aspergillus is the most common hyaline septate mold. And Aspergillus has a characteristic morphology, which is shown here. We have our conidiophore structure, and Aspergillus always end in a vesicle. Some are described as being unicerate, which have one layer of phyllids, which give rise to the conidia. Others have a metula layer, and then phyllids, giving rise to the conidia, and these are described as bicerate. Aspergillus can have a range of clinical disease, ranging from non-invasive, such as allergic bronchopulmonary aspergillosis, where the organism colonizes the airway and the body's response is actually an allergic in nature. Can also have non-invasive fungal balls form in the lung. And then there's more serious infections that become invasive in the form of bronchopulmonary aspergillosis when the organism invades the vesicles and does disseminate. So here's a table showing our 4 most common Aspergillus species, and we'll go through each very briefly. Aspergillus fumigatus is the most common cause of invasive aspergillosis. It grows as originally a white and then turns into a blue-green mold. It is unicerate with the layer occupying the upper 2 thirds of the vesicle. And here's a lactophenol cotton blue prep shown here. Aspergillus niger is the most common cause of fungal otitis externa. It does disseminate, rarely disseminates, but there is some calcium oxalate deposition, and you might be able to see that with polarizing light. Aspergillus niger does grow as a black colony. Distinct though from the Dematiaceus, which we'll get to, if we were to turn this plate over and look at the reverse, it doesn't have that discrete melanin pigment there. The reverse is typically white to yellow. The conidiophores are long. And then what we see here, this species is biserrate, and the structures cover the entire vesicle radiating from the head. And so we can see an example here. You can see some of the pigment. For Aspergillus flavus, this can cause pulmonary as well as systemic infections. It also produces an aflatoxin. It grows as kind of a velvety green-brown mold. The conidiophore is shown here. It is spiky, and that's illustrated there. It can be uniserrate or biserrate, and looks somewhat similar to Aspergillus niger, but Aspergillus niger has some of that black pigment. And then finally, Aspergillus terris can cause a wide variety of infections. Important therapeutic consideration with Aspergillus terris, it is intrinsically resistant to amphotericin B. It grows, as I always say, it's a terracotta-like color or a cinnamon brown color when it grows in culture. It is biserrate, layer of metula and phyllodes, and then can be somewhat columnar in appearance, and showing you an example there. We'll use the next two slides to cover some other clinically significant hyaline septate molds and contrast them to what we just reviewed with Aspergillus. The first being Penicillium. Penicillium is a common contaminant, and then shown here it can grow as this green-blue colony, very similar to Aspergillus. However, when we look at it under the microscope, make the lactophenol blue prep, what is missing from Penicillium species is the presence of that vesicle. There can be metula and phyllodes present, and then the round infectious conidia throughout. And so that's a common example of a Penicillium species. Let's contrast Penicillium with our next mold, which is Paecilomyces. There are two that I want to point out. Paecilomyces liacinus, which has a lilac cover, and Variatii, which has a more yellow-brown khaki color. Paecilomyces is a common contaminant as well, but can cause sinusitis, eye infections, and lung disease. In the case of Paecilomyces, the phyllodes are more elongated, and they taper at the ends. And then difference with the conidia are more elliptical or oblong as compared with Penicillium species. The next is Fusarium species. Fusarium likes to cause fungemia, particularly in patients that are immunosuppressed. This is a mold. Molds don't typically grow from bud cultures, but Fusarium is one of the ones that will. Particularly in patients, like I said, that are severely immunosuppressed, those that have AML or other leukemias. And they like to throw clots and can cause painful skin nodules as well, can cause keratitis infection as well. Fusarium grows as a pink to violet colonies, as shown here. And the conidia are canoe or banana shaped, and these are macroconidia that have septations throughout. And the last two hyaline septate molds that we'll cover are Pseudoallocherium and Scopulariopsis. So Pseudoallocheria boydii has two different names depending on the sexual or asexual state, respectively. It will grow as a very characteristic house mouse gray color in the laboratory. And the asexual state, which is the Scedosporium boydii, has conidia that are unicellular. They're oval, and you can see some similarities with Blastomyces. Can occasionally also have a graphium-like conidiation. And what this means is that all the conidiophores are bound together, and then they diverge here at the apex, and then they bear clusters of oval conidia. You can see those throughout. The sexual state, Pseudoallocheria boydii, forms these large brown cleistothecia that almost look like a Pac-Man type structure. Pseudoalicaria is resistant to amphotericin B, so it's important to recognize that therapeutic consideration. People that get infections with P. boydii include immunocompetent patients. Patients that have suffered a near drowning, and afterwards there's a high mortality with this particular infection, as well as cystic fibrosis patients as well. And then our last organism is Scopulariopsis. Scopulariopsis causes fungal infections, particularly of the toenails. And what you see is the conidia being arranged in chains. They're somewhat pointed at the apex and they have a cut off square base. And then as they mature, the conidia develop a rough appearance and you can see some little spines on them as they mature. So that wraps up the hyaline septate mold. The next category that we'll cover is dematiaceous molds. These molds are going to produce dark colonies due to the production of melanin. We see a colony here, very dark pigment, and then as well as if we look at the reverse of that plate, we see diffuse melanin production. There's 3 types of infections that can occur, and they're usually due to traumatic implantation from the environment. And these go into the cutaneous or subcutaneous tissues. Very rarely would they cause pulmonary or disseminated infections. In general, they're not very virulent. But these 3 classifications are a combination of the clinical presentation as well as what the organism looks like in tissue. So the first is chromoblastomycosis. Clinically, it's seen as warty-like nodules and plaques. But what you see in tissue is a moriform body, also referred to as a copper penny. So that's what's shown here. The next classification is phaeohyphomycosis, where you see verrucous nodules, ulcerations, but you see mycelial morphology. And so it looks like a mole with septations, but we see pigment, and so we can put it into the dematiaceous category. And then finally, a mycetoma. This is typically a tropical infections. There's abscesses with fistula, draining sinus tracts with some sulfur-like material. And typically what is seen in histology is the splendor hypoly-like phenomenon around the grains. It's important to recognize that a couple categories where it has a indication in its name that it is a fungal infection, but it actually is bacteria. And those 2 examples are actinomycetoma, which is caused by the bacterium Actinomyces, as well as botulomycosis, which is caused by bacteria. So I did want to point out that. Here's the most common dematiaceous fungi that you may see. And I broke them down into 2 slides, 2 different categories. The first being this group here are rapid growers, and they have conidial septations. Alternaria is shown here. It's a club or hand grenade-like morphology, and there are transverse as well as longitudinal septations. The next is curvularia. There's usually 4 cells that are present. And with these, there's a central swelling and it causes the curve. These look like croissants, and typically that subterminal unit is the one that is the most darkly pigmented as well. The next example is bipolaris. This has a thick-walled conidia. There can be 3 to 4 to 5 septations, and then germ tubes develop parallel out of both ends of the conidia. The conidia 4 is bent. It's described as being geniculate, and that's shown here in the center. Dreschularia is really not a pathogen. I just include it here because it does look very morphologically similar to bipolaris and can be distinguished because the germs tubes don't come out at the end, they come out perpendicular to the conidial axis. And so that's how they would be distinguished from each other. And then lastly is Excerohilum, which is shown here. These conidia are much longer, have more septations, between 7 to 11. They're thick-walled, and then there's usually this dark pigmented division at either end. The other group of dematiaceous fungi are the slow growers. Then I show you some examples here on the slide. These are going to mature in 7 to 25 days. I'll show you here. This is Phalophora. We have our phyllids here, which are vase-shaped, and they go into a flared collarette where all the conidia are arranged around. Exophylla is a black yeast that matures into a mold over time. The conidia tapers to a narrow point, and then the conidia cluster around that. With Cladosporium, which are typically green colonies, where the conidiophores branch and they have 2 or more conidial chains, which you can see these chains here, and then at the point where they branch, that's referred to as the shield cell. Fonsecaea is the #1 cause of chromoblastomycosis. You can see sequential phyllids with sporulation, and it's described as being these wooden coat rack-like appearance. And then finally, Rhinocladiella. You have the a cylindrical conidia, which are shown here, and they branch from the sides as well as the top of the conidiophore, resembling a test tube brush. Our next category of molds is the mucorales. These can cause rhinocerebral infections, pulmonary, cutaneous GI infections, and they can cause particularly severe disease in patients that are immunocompromised, that are diabetic, and they are angioinvasive. They track along nerves, and they typically stain better actually with PAS rather than GMS. They grow very rapidly. They lift the lid of the plate, and they have this cotton candy-like appearance. We saw an image of this already, but they're ribbon-like, they have broad hyphae, they're prosyseptate, and they have more narrow, more 90-degree branching. Treatment is amphotericin B, and it's important to recognize that the mucorales group is intrinsically resistant to voriconazole. And so I show you some examples here. The most common cause of a zygomycete infection is rhizopus, and this is where the sporangiophore rises directly over the rhizoid. So that's an example of rhizopus there. Leukemia, the sporangiophores arise intranodally to the rhizoids, and this is a picture here depicting that. We have a mucor species where no rhizoids are produced at all, and that's shown here. And then our last two have unique morphologies. Cunninghamella, this is a vesicle that's covered in these spine-like denticles supporting the sporangium. And then finally, syncephalostrum are these chains of spores that radiate from the vesicle to produce this daisy head-like structure. Our last category of molds are the dermatophytes. These are going to cause superficial tinea or ringworm infections that infect hair, skin, nails. They're going to grow on the outermost layer of the skin, and they attain nutrients from the keratin. They typically don't invade tissue. And so you can use a KOH prep for a rapid diagnosis, but culture is preferred. There are 3 genres: trichophyton, microsporum, and epidermophyton, and they are distinguished from each other based on the relative quantities of the micro versus macro conidia. And you can see those listed here. So we'll go over each of these categories briefly. Trichophyton. Trichophyton rubrum is the most common. It's white on the surface, but if you turn over and look at the plate, it does have a deep red pigment, and it's described as having tear-shaped microconidia that are arranged in a pattern like birds on a wire, and that's shown in this picture. Trichophyton tonsurans causes scalp ringworm. It's variably shaped. You can see some club-shaped ones, and then some are more enlarged and have balloon forms. And then finally, Trichophyton megagraphites, common cause of athlete foot. And the microconidia are arranged in these grape-like clusters, and there can be some coiled spiral hyphae that are often seen as well. 2 species of microsporum to be aware of. Microsporum canis causes infections of the scalp and skin of children, also of dogs and cats. And we see macroconidia here that are thick-walled, that are spindled, they have pointed ends, and the surface is rough. In contrast, Microsporum gypsum again, a thick-walled macroconidia, but the ends are rounded and the surface isn't as rough. And then finally, Epidermophyton flacosum has this very characteristic brown, yellow, khaki color when it grows in culture. There are no microconidia, and the macroconidia have a medium thickness to the wall. They're smooth and they resemble a beaver's tail. And so with that, we'll transition into our discussion on parasitology. Parasitology is broken up into two categories, the protozoa as well as the helminths. I did want to point out this reference here. It's fantastic from the CDC. It contains the parasite biology, lab diagnosis, fantastic image gallery, as well as other resources. So the protozoa, we'll start with the intestinal amoeba. And these, the spists are what is spread by the fecal-oral route, and then the mobile trophozoite reproduces and is what causes the disease. So Entamoeba histolytica is a pathogen. It can show ingested red cells. This first row up here is images of the trophozoite form. This particular middle one has an ingested red cell. Entamoeba histolytica is indistinguishable from Entamoeba dispar, but Entamoeba dispar does not ingest red cells. What we see in tissue, Entamoeba histolytica will cause flash-shaped ulcers in the cecum and hepatic abscesses with an anchovy-like paste material. This middle column here is showing Entamoeba histolytica, the cyst form. The cyst form can have up to 4 nuclei. This one has 3, and then there's a chromatoidal bar with rounded ends. We have two species of Entamoeba that are non-pathogenic. It's important to distinguish from Entamoeba histolytica, and they can be distinguished by their size. Entamoeba coli is larger. It can have up to 8 cysts, 8 nuclei in the cyst form. And then Entamoeba hartmanni is also non-pathogenic, but it is smaller. And I will point out that these images are not to scale. So here's a table that shows some very helpful features distinguishing those 3 Entamoeba species from each other. And in the interest of time, I will not review those, but you have them. Some other amoeba that are also non-pathogenic are Entamoeba, or Endolimex nana. And in this case, our trophozoite, it has a very large karyosome that's described as a ball and socket. The cyst can have up to 4 nuclei, and there's no chromatoidal bar. Iodoamoeba bushlei is also non-pathogenic. The troph has a large karyosome, but where you can really make the diagnosis of Entamoeba bushlei is in the cyst form. There's a single nuclei, but then there's this large discrete glycogen mass that's present. And then finally, Blastocysta hominis. Is it an amoeba? Is it pathogenic? It's unclear, but the cyst form is easy to make the diagnosis, and it has this large vacuolar form that pushes the nuclei to the periphery. The flagellate group includes these 3 organisms. Giardia is the most common parasite in the US, particularly in those at camp, daycare settings, people that are traveling. Animals are the reservoir. Our trophozoite is seen here. It's pear-shaped. It has 8 flagella. The cyst has 4 nuclei and some cytoplasmic fibrils, which is shown there. Can be diagnosed by a lateral flow assay, particularly in conjunction with cryptosporidium or PCR or ovine parasite exam. Trichomonas causes sexually transmitted infections. The trophozoite form is shown here. There is no cyst form. It does have 4 anterior and 1 posterior flagella, and then a central nucleus there. Can be diagnosed by wet breath, but not sensitive enough. Most of the diagnosis today is made by PCR. And then finally, we have Dientamoeba fragilis, which is a troph. There is no cyst form. And as its name implies, it's binucleate Dientamoeba. And then the karyosome material is fragmented, fragilis. And typically might get discussed under the amoeba category because the flagella is not evident, but it is actually in the flagellate category. Continuing to the sporozoa, here's a table here. And again, in the interest of time, I won't review them in detail. I'll just point out some general features. These organisms, it is important to know their size to be able to distinguish from each other. And all can be diagnosed using nucleic acid amplification techniques. You can see here the two, both Cyclospora and Cycloisospora autofluoresce, and then Microsporum is actually based on the chitin that's present in its cell wall, is now classified with the fungi, and can you diagnose via PCR or a monophobe trichome scan. So in the couple remaining minutes, we'll try to cover the Helminths real quickly. We have some the intestinal nematodes, which are roundworms. They're shown here. We have Entomoeba vermicularis, which is pinworm, has a direct life cycle. The egg is about 50 to 60 microns in size. I'll point out the characteristic lateral ala around the mouth of the worm, as well as the pin point of the posterior portion. Trichuris or whipworm also has a direct life cycle. The egg is shown here. It's bile stain. It has these very characteristic hyaline bipolar plugs. I show you the worm here. As its name implies, here's the posterior end of the whip, and here's the anterior lash. We have Ascaris lumbricoides. This has an indirect lifestyle, meaning the egg is ingested, but yet the various structures have to go through the lung before it sets up to ultimately cause infection in the GI tract. These eggs are mammillated, which is shown here, and this is the largest roundworm, can range in size from 15 to 35 centimeters. Hookworm, and as well as Strongyloides, these aren't acquired via the fecal oral route. They are both from the direct penetration of skin. They have indirect life cycles. I'll show the egg here, which is a thin outer membrane, and then there's these morula structures that resemble the structure of a coconut, actually. There are two hookworm species that are important to know, Ancyclostoma duodenale, which is shown in this middle image here. The worm has these chitinous teeth. And then Necator americanus, which instead of the teeth has these cutting plates. Strongyloides also penetrates the skin, has an indirect life cycle. Eggs aren't seen with Strongyloides. What the diagnosis is usually made by seeing the worm, and it has this short buccal cavity as well as a prominent genital primordium, and those are what the arrows point to there. Important to note that in patients that are immunocompromised, Strongyloides can cause a hyperinfection and auto-infect, resulting in significant morbidity and mortality. A couple systemic nematodes, which are Anisakis. This is acquired via the ingestion of sushi, cod, and causes immediate GI distress. Oftentimes patients cough up these small worms, which is shown here. Toxocara canis and catty. These are common infections in children, particularly that play in sandboxes and ingest the sand, so important to cover sandboxes after playing to discourage animals from using them. The human is really an accidental host, and so it's going to cause visceral and ocular larval migraines because it's incapable of completing the lifestyle in humans, so it wanders around. And our last example here is Trichinella species. This is acquired through the ingestion of undercooked pork, and it can be seen in tissue having these spiral encysted larval and skeletal muscle, leading to myositis and weakness. The trematodes, so now we've moved into the flatworms. So trematodes and cestodes are both flatworms. Trematodes are commonly known as flukes. These are schistosoma, and these are also acquired via penetration of the skin, particularly in waters that are harboring infected snails. We have two GI forms, Schistosoma mansonii. These eggs are all quite large. Schistosoma mansonia has a lateral spine. Schistosoma japonicum also has a lateral spine, but it's smaller, more inconspicuous. And then finally, the urine form of schistosoma, which ends in a terminal spine, and this parasite is associated with squamous cell carcinoma of the bladder. Showing you a table of some other common flukes, important to, again, size is very important here to distinguish them from each other. I'll use the example of Planourcus. All of these have an operculum, and so the operculum can be accentuated by these dots at the shoulder, which Planourcus has. And then there's an abopercular, meaning at the opposite end of the operculum, a knob. So this is Planourcus. Our middle image here is Paragonymous, which is acquired via crayfish. You can see the shoulder, but no abopercular knob. Fasciola is shown here, that has no shoulder, no operculum, is acquired from ingesting freshwater plants. And then I included a cestode here, Diphyllobothrium laudum, because it has a lot of similar features and can often be confused with the trematodes. And it does have an abopercular knob as seen there. These, again, this is not to scale. So a couple more slides. We'll go next to the cestodes, which are tapeworms. We have our Taenia species, where our definitive host is the human, and our intermediate host is either a cow or a pig. The eggs are the same. They have a thick, radially striated shell. Taenia saginatum is the beef tapeworm. We have the proglottids have greater than 13 lateral branches, which is shown here, and an unarmed rostrum, which is the scolex here. In contrast, Taenia solium is the pork tapeworm. It has less than 13 lateral branches. The ostrum is armed, which is shown here. And it's important to note that Taenia solium, if humans were to ingest the egg, they can become an axodental intermediate host and cause cysticerci in the various organs, the lung, the liver, the brain. Diphyllobothrium laudum is the fish tapeworm. We saw the egg on the previous slide. In this case, the proglottids are wider than they are long, and then there's a very prominent coiled uterine rosette in the center. This can be associated with vitamin B12 deficiency due to where they attach in the small intestine. That's where vitamin B12 is absorbed as well. Dipalanium canis is the dog tapeworm. The eggs have these 6 hooklets present, and then they're arranged in these globular packets. It gets its name because the proglottid has 2 genital pores at the lateral end where the eggs are shed. So that's where dipalladium comes from. A couple more cestodes. We have a Echinococcus, where our definitive host is the canine, and then the intermediate host is sheep and rodents. So these are acquired in areas where dogs are used to help herd sheep. Humans are an accidental host. The eggs are identical to Taenia, like we saw in the previous slide. And the scolex does have hooklets. We can see them here. And then there are 3 proglottids. The last 2 I'll talk about is Hymenalepsis nana, which is the dwarf tapeworm that's shown here. The egg has these 2 polar thickenings that are attached via filaments and then 6 hooklets. We'll contrast that with Hymenalepsis diminuta, which is the rat tapeworm. There are no polar thickenings or filaments, but we do see the 6 oncospheres in the center. And then we'll wrap up the presentation by talking about some blood parasites. So malaria or Plasmodium falciparum. The 2 most important questions to always ask yourself is it malaria and is it Plasmodium falciparum? Malaria is going to be transmitted by the female Anopheles mosquito, which is both the vector as well as the definitive host. Remember that your gold standard for diagnosis is a thick and thin smear, although lateral flow assays in PCR do exist. This panel here at the top shows Plasmodium falciparum. Our trophozoites have a thin, delicate cytoplasm with double chromatin dots. We can see multiple trophozoites within an infected red cell. You can see these applique forms. And then remember, the gameta site is banana-shaped, and this is intracellular. It's taking up the whole space of the red cell. Plasmodium vivax as well as ovale like to infect young cells. So those 2 are going to, the infected red cells are going to be enlarged compared to their neighboring cells. The trophozoites are going to have more sturdy cytoplasm with a large chromatin dot. Our schizont, which is shown here, is going to have between 12 to 24 merozoites. Sometimes you can see some malarial pigment present, and the gametocytes are large to round. Plasmodium ovale. These Plasmodium ovale, all stages show this elongated or kind of fimbriated edges that might resemble a cartoon ghost. The trophozoites have sturdy cytoplasm with 1 to 2 chromatin dots. Schizonts, the mid-verve merozoites, is less, and then this last picture here shows the gametocyte. And then finally, Plasmodium malariae, the trophozoites are going to have sturdy cytoplasm. Oftentimes, there's only a single large chromatin dot. And so they talk about the 3 Bs of Plasmodium malariae: a bird's eye, which is shown here, a band form as the trophozoite matures, and then a basket form. And then I show you here, and this is the schizont. It has 6 to 12 merozoites arranged in a rosette pattern around a some central pigment. I have 2 more slides. This shows blood parasites. The Babesia will contrast that with what we just saw for malaria. Babesia is spread by the Ixodes tick, particularly in the New England area. Trophozoites are more pleomorphic in nature. They can be intracellular as well as extracellular. It's important not to mix them up with a platelet. And then the merozoites can take on these tetroid Maltese cross formation. Babesia lacks pigment, schizonts, or gametocytes. So all helpful ways to distinguish from malaria. We have 2 trypanosoma species, Crucii and Chagas disease. I'm showing you it's transmitted by the Trematine bug. It's present in the American tropics. Our trypomastigote is large. It's going to have this large subterminal kinetopast, and it's going to be C-shaped. And then the mastigotes are found in the infected tissue. This is a cardiac cell here. In contrast to Trypanosoma brucei causes African sleeping sickness. It's transmitted by the bite of the tsetse fly. The trypomastigote had this small, more inconspicuous kinetoplast, and they're going to be more S-shaped or wavy, and there is no mastigote form. And the final slide I have is for blood and tissue microfilaria. I think the one, and I'll just point out, Wucheria, Brugia, and Loa are all sheathed. It's important to know the nuclei and how they're arranged in the tail. And then perhaps the vector. I want to point out Brugia malii in particular has this characteristic pink sheath when stained with Giemsa. And so it's a very easy one to diagnose. And then the last 2, Mancinella and Onchocerca, they aren't found in the blood. They can be found in body fluids, pleural fluid, the tissue, and they can cause onchocercomas, which is shown here. Or other, this microfilaria was found in a pleural cavity. And so with that, I know we're over time, so I will thank everyone for their attention. There are some slides here at the end to share with you some high-yield points on virology, but thank you for your attention.
Thank you, Dr. Stempak. It's always difficult to get all through the whole thing, but that was a lovely review, especially of the parasites. I know, and mycology. There's pretty high yield, and then you guys also have the handout that Dr. Stempak has already. Did you put it on the thing here, Dr. Stempak, or you send it to me?
Yes, no, I shared it with them prior to starting my talk, so it should be in the chat.
So they can take a look at that too. I think there's a wonderful presentation. I know we are already a little overboard in terms of time. So what we are going to do is probably eat into our break at the end of term. So what we'll do is give it about 5 minutes. Do we want to start at 2:17 then? Because we only have 3 minutes for a break. That's not even a proper break. So 2:17. Why don't we get back here at 2:17 for Dr. Spicer's presentation on DermPath?
Sounds
And
good.
if there are any questions for Dr. Moore or Dr. Stempak, if you guys can directly reach out, and Dr. Stempak and Dr. Moore, if you're still around, if you can stay back for a few more minutes, if there are any direct questions. It's Dr. Spicer. Sorry, we are a little late.
No worries.
Good to see you. Good to see
Good
you.
to see you
Yeah.
on this lovely
They can
rainy
take a break.
day.
What's that?
On this lovely rainy day.
I'm at work. Actually, I crashed into someone else's office because there was scheduled power out. Oh, wait. Let me pause the recording on this. I'm sure.
Oh,
Thank
good.
you, thank you.
Okay.
God bless you. But they are not going to forget. I know that. That's why, there. So I think I started. I know that you guys are on top of it and you're still alert.